Good morning and good afternoon. I am Dr. Stefan Wallace, and on behalf of the COVID-19 Prevention Network, I want to thank you for joining this episode of COVID in Black, Episode 3, which will focus on health inequities and the legacy of medical mistrust in Black communities. Before I introduce the panel, I want to mention that the CoVPN has been organized in response to the COVID-19 pandemic to test vaccine and monoclonal antibodies that are designed to protect people from COVID-19 disease. For more information about the CoVPN, please follow us on Facebook and Instagram at Prevent COVID-19 and visit us on our website at www.preventcovid.org. In today's episode, we will focus on the COVID-19 related inequities and the role medical mistrust plays in reinforcing these inequities. Our panel of researchers and medical experts will also discuss some of the causes of health inequities in the United States, the factors which contribute to medical mistrust in Black communities, and what Black people can do to address concerns related to vaccine hesitancy and lack of confidence in clinical trials. The panelists will also begin to unpack the legacy of medical exploitation of Black people and why Black communities should consider participating in clinical trials today. For our audience, everyone on Zoom will be muted. Please use the QA feature in Zoom for questions to the panelists only. If you are with us via Facebook, please use the comment feature in the thread to ask panel questions. We will likely not get through all of the questions that are asked, so visit our social media channels to engage in conversations and get answers to your questions. And also visit our FAQ section on the CoVPN website for answers to many questions. Lastly, I want to offer a disclaimer that the views and statements made by the panelists in this broadcast are their own and may not represent the views and positions of their home institutions or the CoVPN. Now I will introduce our illustrious panel. First is Dr. Ugochi Obana, Associate Professor of Medicine at Emory University in the Division of General Medicine and Geriatrics. She's an Associate Professor, she's the Chief of Geriatrics Services Line at Grady Memorial Hospital, where she is also the Medical Director of the Acute Care for the Elderly Service. She has also served as the Medical Director of Grady Geriatrics Outpatient Clinic. Next, I will introduce Dr. Vivian Carter, who is the past president of the National Hbcu Research Network for Research and Health Disparities. She is also a former assistant director for community outreach with the Tuskegee National Center for Bioethics. Dr. Carter currently serves as the chair of the Department of Psychology and Sociology and the deputy director for community engagement at Tuskegee University. Dr. Carter is an experienced social scientist with specialties in organizational development and transformation, medical sociology, race, and gender relations. And last but certainly not least, we have Greg Millett, Vice President, AMFAR, Foundation for AIDS Research, and Director of AMFAR's Public Policy Office. From 2000 to 2009, Mr. Millett served as the CDC Senior Scientist in the Division of HIV and AIDS Prevention, and subsequently as a Senior Policy Advisor in President Obama's White House Office of National AIDS Policy from 2009 through 2013, where he helped author and implement the National HIV/AIDS Strategy. Mr. Millett is a nationally recognized expert in HIV racial disparities and has first authored publications in The Lancet, JAMA, AIDS, AJPH, and JADES. Welcome to our panel. So I want to start by asking a question about health disparities. And really, for any of you to respond, what are the COVID-19 related health inequities that we're seeing in Black communities?
Sure, I can go ahead and begin. What we're seeing with COVID-19 is unfortunately a familiar trajectory. We've seen it with HIV, we've seen it actually with H1N1, the other respiratory illness from 2010 that was also a pandemic, though not to the degree of COVID-19, where we see that over time, we see higher rates of disease burden, diagnoses, hospitalizations, as well as deaths in communities of color. And what we've seen, particularly with COVID-19, is just how quickly we have seen these disparities take place. So for instance, we're seeing greater rates of infections among youth of color. We're seeing greater rates of infection among elderly individuals of color. We're seeing greater rates of infection in nursing homes that have primarily Black or Latino residents. The degree to which we're seeing the disproportionate impact in communities of color, and by that I mean Latino Americans as well as Native American communities, is really widespread. And part of that is because of the social determinants of health. We have not addressed the social determinants of health that place communities of color at high risk for COVID-19 and, quite frankly, other diseases in the United States. And by social determinants, I just mean broadly income. If you have a lower income, you have higher mortality in the US. You see that in study after study, no matter what disease there is. Employment, we see certainly for COVID-19 that those individuals who are employed are more likely to be employed as essential workers in jobs that place them at higher risk for exposure for COVID-19. And there are studies that show that Black and Latino households have a higher proportion of individuals, over 50% of these households have a higher proportion of individuals who have to work outside of the home. So that places them at risk. We're also seeing healthcare access as another issue. It's a shame that right now the federal government is looking at potentially getting rid of the Affordable Care Act, because the Affordable Care Act put another 20 million people into care, including Black and Latino and Latinx and Native American communities. And with the COVID-19 pandemic, it's clear that those individuals who don't have access to health insurance are less likely to be tested, they're less likely to be in care for COVID-19, and that unfortunately has a disproportionate impact. And then the last thing that I would say is that it's not just a disease itself that's impacting communities of color, it's the economic recession that we're also seeing as part of COVID-19 that's disproportionately impacting communities of color. We're seeing from, unemployment rates that are higher among Blacks as well as Latinos. We're seeing eviction rates going up and foreclosures primarily in Blacks and Latinos as well. We know that if you're unemployed, that means that you probably don't have access to health insurance any longer, because in the US, a lot of our employment is tied to health insurance. That affects COVID-19. And if you are homeless, or if you have to share a home now with multiple people, that also increases risk for COVID-19 transmission as well. And then the last thing that we're seeing, that's also part of this whole issue of the economy, is that they are estimating now, the Stanford Institute of Economic Research is estimating that about 40% of Black businesses are not going to survive the COVID-19 pandemic. For immigrant businesses, it's 36%. For Latinx businesses, it's 32%. And for Asian businesses, it's 26%. And now you juxtapose that with just 17% for white businesses, and you see that we're not only dealing with disparities in terms of disease, but also disparities in terms of the economic impact.
Can I also add to that the impact that it's having on rural communities in regards to, number one, having healthcare facility, the access issue that we have to deal with, as well as, of course, you're talking about the economic impact.
From a clinical perspective, also, you find out that a number of African Americans tend not to do too well when they're admitted to the hospital. And so in comparison, because a number of them are already predisposed by having things like diabetes, high blood pressure, other underlying comorbidities. So by the time they get infected with COVID, they ultimately don't do too well and end up in the ICU or end up dying. So there's a high mortality rate also, in addition, due to some of the factors that have led to their having predisposing conditions, and ultimately their outcomes are poor.
I just want to add one quick point, particularly to the last point. The one thing that you see usually in the discourse around any type of health disparities in the United States is a degree of victim blaming. And we see this victim blaming that's leveled at communities of color. We've seen it with HIV, such that, with the high rates of HIV in communities of color, there was this perennial question, well, why are they engaging in so high rates of unprotected sex or drug use? But when you actually interrogate the data, you find that African American communities overall engage in less unprotected sex. They have fewer sex partners, less drug use, but still more likely to have high rates of HIV. And it's because of the social determinants of health we discussed before. The same thing is operating right now with COVID-19. Even though you see higher rates of diabetes, of cardiovascular disease, of other conditions that we know predispose people to higher rates of hospitalization for COVID-19, we find that those underlying conditions are not associated with the greater degrees of diagnoses of COVID-19 in African American communities. We found it in studies that my team and I have published. It's been published in several other studies that have been done, some very large studies of over 5,000 individuals, where they're not finding that association with underlying health conditions necessarily in the high rates of COVID-19. In fact, there's studies that are showing that African Americans are more likely to social distance, we're more likely to wear masks compared to white Americans, but we're still at greater risk for COVID-19. And last, there are studies that really underscore the degree to which the social determinants of health are important. So for instance, there was a paper that was published in JAMA where they looked at across 92 hospitals for higher rates of COVID-19. They found that Blacks and Latinos had higher rates of COVID-19. But in multivariable analyses, when they adjusted to see what factors were associated with it, as soon as they adjusted for socio-demographic factors, those social determinants of health that I discussed beforehand, you saw that all of the disparities disappeared, which means that we're not dealing with these underlying social issues that are predisposing Black, Latino, Asian, and Native American communities for higher risk for COVID-19.
Thank you all for that. Thank you all for that. I appreciate especially the comment about victim blaming and how we really need to unpack that. All three of you have talked a bit about social determinants of health and sort of the impact in different ways. I'm sort of curious to hear from your perspective, what fuels these social determinants?
I'll start with that. I think a lot of what fuels a lot of these social determinants is systemic racism. A lot of it is built into the system. And when we talk about, in terms of economics, even in terms of housing, those things, those discriminatory, what we call those microaggressors, are present. We even see them, studies have shown that even when, especially among African American women, and when we're talking about infant mortalities, we think even when they have the same economic base, we still have higher rates of infant mortality. And you're wondering, okay, they've done everything, they're in the same economic class, everything is equal except for that one thing. And it boils down to the treatment within the system, for some of them in terms of how they are perceived and how they are treated within the system. And in terms of economics, we know that. So for me, one of the main points is the systemic racism.
So not having or having a certain salary is not a protective factor, will not alleviate, the impacts of racism and the determinants that you all are describing.
You can ask Beyonce and Serena Williams. Did it help them? Okay, so it's there, and I think that the medical community and even academia itself, in terms of how we're training these professionals, we have to acknowledge it and be upfront and in addressing it.
Yeah, I can't underscore anymore, what Vivian is saying. It's certainly systemic racism. And the pernicious part about this is that the systemic racism are structures that were set in place decades ago. maybe even over a century ago, that still have effects on our lives as communities of color. So for instance, there have been several studies that have looked at those places in the southern United States that had a higher proportion of African-American slaves, and then looked at them today to see what types of policies are in place in those places. And those places have higher rates of resentment towards communities of color. They have policies that prevent communities of color from having higher rates of job access, employment, as well as healthcare, and all of that is related. I think it's the same thing too that puts a finer point on this in some ways, is that there have been several studies that looked at COVID-19 for higher income communities. And there's one that was published in JAMA 2 months ago. And they found that even with African Americans with high incomes, they still had higher rates of COVID-19 compared to whites with similarly high incomes. And the thing that we have to realize is that not all of this is just COVID-19. These disparities long predate COVID-19. There was a recent paper that came out that basically said that, that white Americans would have to have 6 times the rate of COVID-19 mortality to equal the disparities of mortality that we see in African Americans pre-COVID-19. So these disparities have been high long before COVID-19. We're just looking at it now because of COVID-19. And then one last thing that I would say too is that, it's clear that racism has these effects. As scientists, the scientific community, I can say reliably, has been fairly blind to this. There are very few papers in the scientific literature looking at the effects of structural racism and looking at it seriously. But there is one paper that was published. It was a meta-analysis of 300 studies, and they found that racism was significantly associated with poorer mental as well as physical health in communities of color. This is something that exists. If we're not going to deal with these structural issues that place communities of color at higher risk for disease, then we're fated to keep having these conversations over and over again and keep saying these same disparities with new types of diseases that come along.
I agree.
Thank you for that. Ugochi, as a clinician, it would be great to hear from your perspective. How does systemic racism come into play in clinical settings? Oh, you're muted.
Sorry about that. Yeah, so multiple ways with regards to patient, the disease burden. It's something that we see quite often. But on the other hand, there's also the perspective which a number of institutions are trying to deal with right now with regards to bias and how patients are cared for as a result of preconceptions, even amongst healthcare providers. So a number of institutions right now are making efforts to try to deal with that bias that affects the way that patients are handled as a result of that bias. And so that's really very important to address. And that would affect the care that's provided to the patient. That would affect multiple factors that come into the care of the patient. And so it's really very important that that's addressed.
As in your work with your unit at Grady, are you seeing the impact of systemic racism in ways, seeing the impact of systemic racism in terms of the patient population that you're engaging? And I guess I'm really also particularly interested in hearing about your experience with providing care to older populations.
So in general, most of our patients, I would say, are predominantly African Americans. We have some Latinx patients also and other minority patients, but in general, we deal with or we take care of all minority patients, African Americans who are from who are indigent patients. So essentially the care that's provided is to be able to take care of those patients. Grady was essentially established by Henry W. Grady, who in the 1800s was very concerned about the care that's provided to indigent patients. And so that was the whole idea. And so also we're finding that a number of our patients, the burden of disease is certainly much higher amongst our patient population. I had a resident recently that I worked with, and one of the things he told me as part of the feedback was that it was much harder to take care of the patients who were at Grady in comparison to some of the other institutions where he had rotated through. They are less complex patients, and it's all as a result of the social determinants of health that we had talked about. So you find out that these patients are much more complex to care for because of the comorbidities they have. And so you're trying to address that. You're also trying to address the social issues that affect them. With regards when you're sending a patient home, you're thinking about things like, are they able to afford their medications? Do they have a place to go back to? And how much support do they have? So those are all the things that fit into the care of our patients there. And of course, our older patients at Grady are also much more frail. And so we're having to deal with that, not having as much support at home. So those are some of the factors that we deal with. I'm not sure if that, has answered.
Yes, that was helpful. Thank you. So I guess I'm sort of curious now before we transition into talking a little bit more about clinical trials. With all of the complexities and the layered impacts of the things that you all have described, what is the hope? What is the thing that keeps Black folks going? What is the thing that Black folks need to consider with respect to all of the sort of underlying factors and environmental and social impacts that you all have described?
Well, I'm going to jump in here because I do a lot of the community engagement and working with what we would call at-risk communities. One of the things that I think, is to educate, to make them aware. A lot of times, especially here in rural communities where we do not have direct access to medical facilities, we may have a couple of clinics, but there's no actual hospital located here in Macon County. One of the things that we do is to educate them. Like I do a lot of work in breast cancer. I educate women about self-exam, about what cancer is. When I first started working in that field, we had the highest cancer mortality rates for breast cancer. But, everybody was saying, okay, education. We did educate, but then we also had to combine that with being proactive in those communities and ensuring that, number one, when I started, there was no place in Macon County where a woman could get a mammogram. I could educate her all I wanted, but she couldn't get a mammogram. So we fought to make sure that we had mammography established here in the clinics here in Macon County, just to make sure that these women who are now empowered with the knowledge about it were able to get their mammograms. And then also talking about them being proactive in terms of how they speak with their doctors. A lot of women were saying, well, my doctor never even, asked me, or, whether it ran in their family or even told them about what age they should be concerned about this, or even suggested getting a mammogram. And these are women, well into their 40s. And you're like, wait a minute. So here they're going for their annual checkups. They're talking to their physicians, but the physicians are not suggesting. But you have to, again, educate yourself, ask, be able to talk with your physician. And as I tell people all the time, if you have a physician who feels like, well, that field gets defensive when you ask a question, you probably need to look for another physician.
Yeah, I'm sorry.
Sorry.
Go ahead.
Yeah. I would like to add to that. I know that a major part of care, and I absolutely agree with Dr. Carter about education and empowerment. I think that that's very critical. I think that the more we are empowered to understand what we're dealing with and to understand the treatment modalities, I think it's really important for people to think about prevention for a number of things that happen, whether it's breast cancer, whether it's HIV, whether it's diabetes. It could just be that even for something like diabetes, you may have a family history, but if you're proactive because you understand that there are certain risk factors that increase your risk, then you make every effort with your diet, you make every effort with exercise and so on and so forth. So I think that a whole lot would depend, amongst other things, as much as we can, to make sure that we're empowered in the knowledge for a number of the health conditions. We have patients who come in, who look on the internet and ask questions. And I think that that's great. I think that understanding what they have to deal with plays a whole role in their outcomes. So I think that the Black community should understand that. I think the era for not being able to communicate with your provider, the era for not understanding what's going on with you, the era for not being proactive about your health, understanding that it's your body and being proactive when you interact with a healthcare provider is, I think that era should be over and that people should be empowered. And also what Dr. Carter said about access is so important, right? That makes a difference. So no matter how much you know, if you don't have access to certain basic things that would help improve your mortality, to cervical cancer screening early enough, to be able to pick up cervical cancer, or mammogram to be able to pick up on breast cancer. If you don't have that access, then definitely you won't be able to do that, and that affects your outcomes. And it would be that you already have developed cancer or it's progressed a great deal before a diagnosis is made. So prevention is very key. Also, thinking about things like, and I know we're going to talk about it, participating in research, participating in trials, I think is also key, because ultimately the choice of treatment modalities, let's say medications, there are certain medicines, blood pressure medicines, that have been found not to be as effective in African Americans in comparison to white Americans. So it's important that we participate in these trials to know what medications are more effective in our population, so that physicians know and they're able to prescribe better, knowing that those medicines may not be as effective.
And Stefan, I'd like to answer the question, but I'd like to frame it in two ways. First, the things that frighten me, and then the things that give me hope. So in terms of the things that frighten me on the horizon, is the fact that only 10% of the American public has been infected by COVID-19. So very few of us have been diagnosed or infected with COVID-19. There is a long way to go. And with our current policy from our administration of essentially going towards herd immunity, which basically means that we're going to let this virus just rip through the country, really means that it's going to disproportionately impact communities of color. It's going to disproportionately impact African Americans in specifically. That's something that frightens me. We cannot have a policy of dealing with this virus that continues to be haphazard, where communities of color are disproportionately at higher risk. The other thing that concerns me as well is just the cost for COVID-19. The Congressional Budget Office came up with an estimate saying that this is going to cost us upwards of $9 trillion over the next 10 years. What does that mean for funding for public health? What does it mean for funding for community-based organizations who really do a lot of the heavy lifting and the work that we need in creating access as well as trust within communities? What does it do with just dealing with other diseases that we know that we need to deal with within our communities, such as HIV and others? We're going to be paying for this pandemic and paying for the mishandling of this pandemic for quite some time to come, and that's going to disproportionately impact the health of communities of color. But for two quick things that do give me hope, one of them is the high proportion of white Americans who participated in the Black Lives Matter protests this summer. it was amazing to see so many white Americans, different ages, who really understood, where it seemed to crystallize that racism, and particularly systemic racism, is an issue in the United States and something that we need to do something about. That gives me hope, because I'm 52 years old, and I can tell you that in the 80s and the 90s and even in the early 2000s, I never thought that I would see a plurality of Americans saying that this is an issue. That gives me hope that we could actually change it. But the other thing that gives me hope as well is the fact that the demographics are changing. By 2044, this is going to be primarily a country of communities of color. And that means that out of necessity, things are going to have to change. Our laws are going to have to change. The way that we come up with our laws have to change. There have been studies that have looked at policies that we have that are related to health, and they find that they disproportionately discriminate against African Americans, Latinos, and others, because these are policies that are primarily done that benefit white Americans. And there are data that show that. There are also data showing that, even in the Senate, I'm here in Washington, D.C. In the Senate, of course, everybody knows there's 100 senators. The senators have staff. These staff are incredibly influential in making policy positions and crafting policy that deal with the health and our lives of all Americans. When you take a look at the composition of the staff in Congress for senators, only 11% are Black or brown. 11%. 89% are not. And these are the people who are crafting our policies that's influential in our health. So that's why I am guardedly optimistic that with the demographic changes that are coming, we're also going to be seeing changes in policy and more representation to make sure that we can get to the issues of equity that will make it easier for Black, brown, and other communities to have a same amount of advantages as other communities have had traditionally.
Thank you all for that. So, and Ugochi mentioned it about the importance of clinical trials with respect to looking at effectiveness of medications, but also the diversity of medications available to our communities. I'm sort of wondering, from your perspectives, what are the biggest challenges that Black communities are facing with respect to engaging in clinical trials?
Okay. Well, the biggest thing that they're facing is they don't trust it. They do not trust the research, number one. And the thing that you have to understand is that before you ask me to participate in something like this, think, what has been your track record? Okay. Everybody knows where I am. Okay. I'm housed here in Tuskegee. Okay. But people forget that, beyond Tuskegee, we're still seeing the same types of abuse. So we can't just say, oh, that was Tuskegee, that happened in 1932, and then it's done. It's not, because you keep perpetuating these same types of abuse. And yet you're still coming and asking the community, and especially African American communities, to participate. Also, right now, the politicalization of the vaccine itself. When you see it used as a political tool, that's a red flag. We know this. And so these are things that we have to begin to separate, and we have to begin to really examine. And one thing that I want to say is that, especially one of the things that we found out when you had a shortage of the of screening, screening for the vaccine, when you had a shortage of the materials, Tuskegee decided, wait a minute, we have the ability to make the medium in our laboratories. Do you know that we actually, our faculty, brilliant young professors, went into the chemistry labs and the biology labs, and they made the medium and actually gave it to the state so that we would have enough to screen the people in the state of Alabama. I think you're missing a very crucial component is to invest in the HBCUs, because the populations that you're talking about reaching, and I'm talking about from the bench, not just trying to round us up to go out and, recruit people, but you have bench scientists who could work directly with you so that we can then communicate with our communities, because most HBCUs are located in Black communities. Many people, the people know them, people trust them. They've been working in conjunction with one another. Invest in those communities so that you've got a pipeline from all the way going from the bench to the curbside or the bedside. That you have people that they trust and that can communicate to them exactly what's happening. And we need to be clear and transparent. Our communities also need to know what questions to ask. Okay, they need to know their rights when participating in clinical trials. They have rights. They need to understand the ethical implications. And of course, that they need to understand also that at this point in time, as Greg and others have mentioned, we are about to turn the corner in terms of the diversity in our communities. Okay, in terms of the population. So we can't afford to sit on the sidelines. The reality is that we have to get involved. But it is about how do we do that? We need to do that from a point of knowledge and understanding and trust. And we have to work at building that trust. And that trust means that we invest in the community at all levels and actively be engaged about the process.
Yeah, I agree completely with what Vivian has mentioned. I mean, there's a history that's here. There's certainly Tuskegee, but it also predates Tuskegee. I mean, there's a rich history of slave owners who medical experimented on slaves, these unscrupulous physicians. And then unfortunately, we have a lot of contemporary examples too that fuel mistrust in Black and brown communities. So for instance, we see, with the opioid crisis, that African Americans were systematically less likely to be prescribed opioids compared to white Americans because doctors believed that African Americans were more likely to take the pain that's associated, that any type of pain that they have compared with whites. And they were also afraid that African Americans were more likely to become addicted compared to whites. So what you see is this asymmetric opioid epidemic that's more affecting whites compared to Blacks, primarily because of racism, because physicians were less likely to prescribe to whites. We're also seeing the same thing with opioids as well when it comes to having access to opioid substitution therapy, such as buprenorphine. Because of lack of access to health insurance, African Americans are less likely to have access to that compared to whites. We even see it in just transplants. You see that for, African Americans are less likely to receive a kidney transplant compared to whites, more likely to wait longer compared to whites for transplant. So we see this over and over again. And there's actually a recent article in the New England Journal of Medicine where they catalog these systemic biases in medicine that disadvantage African Americans across the fields of cardiology, nephrology, obstetrics, and urology. So this is something that we see over and over again. And unfortunately, we haven't learned our lesson well, because even with COVID-19, we're doing the same things where we're disadvantaging Black and brown communities. So for instance, when a COVID-19 test was available, you saw from the very beginning with the rollout of tests within communities, they were being rolled out in primarily white communities all across the country. We saw it in Texas, across all Texas cities, all throughout New York City, through Chicago, through Boston, through Tennessee. There's all these papers that are cataloging that we were testing in communities where there are going to be lower rates of COVID-19 but not testing in the communities, Black and Brown communities, where there are higher rates of COVID-19. So unfortunately, we have this pattern that we see in our nation where we systematically devalue the lives of Black and Brown people as compared to whites. And it's continuing right now in the COVID-19 era, and it certainly feeds the mistrust that African Americans have against the COVID-19 vaccine.
Thank you for that. So there's been quite a bit of conversation about the relationship between racism and the medical establishment. And I think we would all agree that, you know, medicine and the medical field is predominantly white men in terms of the persons who are involved. And so I guess, you know, a question that was asked, and I'm also sort of wondering, in addition to increasing the number of providers who look like us, what, in your opinion, is the role of Black medical providers and Black medical associations in response to COVID-19?
I think that we play, as healthcare providers, play a critical role. One is having an understanding of the population, being able to relate, provide more compassionate care because there's an understanding of the patient population that you're caring for. I think also that there is a role of Black doctors and Black healthcare providers to increase the awareness of the population in general. And for me, a whole lot, which we had said before, has to do with that empowerment, the role that we play in empowering the population, in having a good understanding of the various disease forms and how that operates, and the place of prevention, essentially, like we had said, in trying to reduce the disease burden. I think that healthcare providers in general play a critical role from that perspective. So you have the perspective of prevention, and then you have the perspective of when the patients are now in the hospital, how they are handled. But I think that the initial part that we play a major role is advocating for our patients and advocating for our population in making sure that they are well empowered to prevent some of these diseases and the disease burden. I think that we play a critical role there. So.
Can I add? I think that physicians play a critical role in advocating for more diversity and in their field. I think it's very important in your organizations, even in the academy, you know, in terms of changing the literature, changing the teaching models that are out there. I think you play a crucial role because you are there.
Yeah, I think that that's a great point also. And I believe that increasingly over the years, there's a realization that that's the case, that the population or the diversity of the population of healthcare providers that we have in comparison to white Americans is, of course, the numbers are much less. And I think that increasingly a number of the healthcare institutions are beginning to see that and understand that, and are making some efforts to make sure that that diversity is increased. But certainly we have a long way to go because in being able to care for patients, being able to provide culturally competent care, being able to provide care with compassion will be having providers who are well placed. Sorry about that. Sorry. I'm sorry, they're calling me about a patient. Yeah, but I think that increasingly there's that understanding by a number of healthcare institutions, but there's certainly a long way to go in trying to make sure that we have enough population of African Americans, of Latino physicians, just to make sure that of nurse practitioners, of the various healthcare providers that are in the healthcare field, to be able to provide care that's compassionate, because you do understand where that patient is coming from. And so you're able to provide care appropriately. A little bit of what Greg said, I know that several studies have been done showing that access to certain things, certain procedures, as a result, not even as a result of that procedure being available or it not being available, but much more from the perspective of bias that makes you able to provide certain procedures or refer patients to have certain procedures in comparison to African Americans, where they are not referred for those procedures, all as a result of bias. But I think that over the years, and more recently, there's been a trend towards understanding that those aspects of racism, of systemic racism, exist, and in increasing the number of providers who are minorities.
So we've talked about community engagement, we've talked about investing, we've talked about speaking to the people directly, we've talked about building trust. And so to sort of circle back around to some of this, but also to expand or dovetail off of what you all were just talking about, I'm sort of wondering, what are the messages that we need to give to communities to help them understand what clinical trials are, what the COVID-19 clinical trials are, and to help build this trust? What does the investment that you described, Vivian, look like? And how might communities advocate for that investment? And what is the responsibility of other groups, other organizations to make that investment?
Let me start first off by saying, in terms of the funding agencies, I'm going to start with them first and foremost. Funding agencies need to invest more in HBCUs if they're serious about addressing some of these disparities, especially as they affect minority populations. You have to invest in not just HBCUs, but even the tribal colleges, as well as those Hispanic serving institutions. That's number one. Then we want to move down to, again, and then that's talking about the development of that cadre of educators, of physicians, of researchers. You gotta, they have to be in place. Then at the community level, when I'm talking to people about community, the first thing that I say is you cannot just come into a community when you want something, okay? You have to be a presence. You have to get to know the community, get to know the people, engage them, even when it's time, when you don't want something, so that when you do, you know the people, they know you, and you have to be transparent. You have to be honest. One thing that I continually tell people is that, even if you catch the cancers early, that doesn't guarantee that you're going to survive, but it increases the likelihood. We catch it early, then there are things that we can do to treat it. That's what, you have to be honest. I'm not trying to come out here and give you this silver bullet. You have to tell them what the risks are. You have to respect their autonomy, their right to make a decision. When you explain things to people, and I just say in layman terms, don't come at me with all of the clinical jargon, because a lot of times that completely goes over their head. But come at me in layman terms, so terms that I can understand. And be honest and upfront about what the advantages, disadvantages, and what my rights are. And specifically, you want to tell them how you're going to use their the data that you get from them? How is it going to be used? How long? We always talk about informed consent. And a lot of times at institutions, informed consent is about the legal side. What keeps me from violating any of the legal standards instead of thinking about the human side? What keeps me from violating this person's human rights? Recognizing, would I do this to my mother? Would I put my mother in this? Would I do that? So, we have to think about it in those terms. And again, to me, it is to be upfront and transparent about the process, about what is happening, about what their rights are as participants, and give them the right to say, and be content with them saying no, because it's not for everyone. The other thing, but what I will tell groups that are going out and trying to recruit people, you won't get if you don't ask. A lot of times people say, oh, the reason why we didn't go to that community is because African Americans don't participate in, we found out they don't participate in clinical trials. Well, I found out that's wrong, because I found a whole group that do. But it is about, again, being upfront, being transparent, acknowledging their rights.
The one thing that I would add to that, it's not just the message that we frame, but the messenger really matters. So it's clear that who communicates the message is just as important as the message itself. And we're not out of the woods when we take a look at vaccines. Just for the flu vaccine, you take a look at vaccination coverage for African Americans. For 2017 to 2018, the CDC reported only 30% of our community was vaccinated for the flu in that period. For 2018 to 2019, only 40%. So it only went up 8 points. 40% were vaccinated for the flu. Most African Americans are not getting vaccinated for the flu. So if we're not getting vaccinated for the flu, what do we think is going to happen for a new vaccine where it's being politicized, where there's all this controversy that's associated with it? There's a lot of work that we have to do. It doesn't mean that we can't do it. It certainly can get done. But there's a lot of work that we have to do. And a lot of that is the messenger. For instance, there was a poll that came out last month that said only 2 in 10 Americans would take the COVID vaccine if it were recommended by President Trump, whereas much as 6 or 7 in 10 Americans would take the vaccine if it was recommended by a friend, a family friend, or their family doctor. So there's a difference in who the messenger is, and we have to be clear about who the messenger should be in the Black community. One thing that worries me a little bit is I've seen with researchers in my decades of research who have really related to an old model of messaging within the Black community. They only go to the Black church. The Black church is important. The Black church is not the whole Black community and doesn't message to the whole Black community. We need to be much more savvy. We need to get influencers who are online and make sure that they're carrying messages for us on TikTok or Instagram or other posts. We need to, figure out other individuals who also hold sway beyond the Black church, who could really get these messages out for us. And I'm hoping that that's something that we will be able to do as part of the COVID-19 vaccine trials, is to really modernize our approach about who the messengers are and the types of messages that we convey, so that we can even eclipse the coverage trials that we're seeing right now for flu vaccine in our community, that it could be even larger than that for COVID-19.
And what would you say to people, the messenger, the message, what would you say to people, our people, who don't believe that COVID-19 is a threat?
I think from a clinical perspective, I would say that COVID-19, I think that there's a perspective from, several people. If you haven't had someone close to you suffer from it, you don't realize how real it is. And not just how real it is, I would say that COVID-19 has been, I would say that from a healthcare perspective, that it's one disease that came and affected multiple systems, and healthcare providers were grappling with trying to understand what this disease really is, because multiple organs were involved at the same time, unlike several other viruses that we have had that haven't affected humanity as much. This disease came, affected multiple organs, and killed lots of people. So I think it's very important that people realize how real it is and how devastating it is. I've lost close people to me with no underlying health conditions. And so besides even seeing patients, when you see those who are close to you grappling with that disease, you realize how real it is and how important to take measures to try to prevent as much as possible. I know that there's a lot of mistrust with everything that's gone on over the years, but I would also say that it's very important that we're properly represented in the trials, whether it's older adults, whether it's African Americans, that we're properly represented, because that's the only way we can find out the efficacy of the vaccines. And we're able to trust the vaccines that come our way when we know that we have been represented in those trials and know how efficacious those vaccines really are. And so it's easier for you to trust. If that process is transparent, it's really important that the development of the vaccine is really transparent to the population so that the trust is acquired to be able to accept the vaccines.
Yeah, I think that Dr. Ogochi is exactly right, that the main operant here is trust. We have to make sure that we as clinicians, as providers, as physicians, as scientists are deserving of the trust of the Black community, and that we're going to be able to make sure that we build upon that trust when we recommend which vaccines people should take. The data that I'm seeing, I'm not seeing African Americans saying that COVID-19 is not a concern to us. In study after study, in poll after poll, you see increasing numbers of African Americans from month on month who say that they are afraid that they might unknowingly spread COVID-19 to others, that they might get COVID-19 themselves and require hospitalization. We're seeing that increase over time. The only group where it's decreasing is among whites who have been seeing the data and are realizing that perhaps they're at less risk for COVID-19. And it's also really clear too, when you ask African Americans if they've known someone who died of COVID-19 as early as June of this year, 1/3 of African Americans said that they already knew of someone who died of COVID-19. I fear that that's actually even higher now than that 1/3 that we saw in June. So I don't think that the issue for us really is, concern about, or not concern, but not seeing that we are at risk for COVID-19. I think the threat is sufficiently there, and that has definitely come through in our community. What has not come through is the trust piece. We have to make that link, that bridge. Okay, the threat is there. Now, in order to do the action of getting vaccinated, we need to make sure that we build upon the trust that Dr. Ogochi as well as Dr. Carter really have been talking so fantastically about during the session. And this is something that is our cross to bear as providers.
Thank you for that. What would you say to those who decide to wait for others to take a COVID-19 vaccine before they choose to receive it?
I would say that's okay. They have that right.
I would understand where they're coming from. No one wants to be used as an experimental agent. You would rather want to see what happens to those who take the vaccines. But I think that it goes to the fact that it's really very important that the process of the development of the vaccines is transparent so that people can trust that whole process and are able to come forward to get the vaccines. I know that with the flu and with other vaccines, there has always been that challenge with taking vaccines because you see people who have reacted to it and you don't want to be the first person to go forward and take a vaccine and subsequently have a reaction to it. So it's certainly understandable. But I think it should come more from the perspective of the developers and to make sure that we know what that process is and that we have representation on the panels, which is great for the CoVPN, to make sure that there's adequate representation on the panels who are reviewing these protocols for the vaccine, to make sure that there's adequate representation so that it helps build the trust amongst our population to be able to accept the vaccine. If I know that I have sufficient representation of African Americans, or if I know that I have sufficient representation of geriatric experts on the committees that review the vaccines, then I know that to some extent I would trust that, well, these are people who have expertise in this area and that they participated in the review of the protocols for these vaccines, and I would feel more comfortable in taking the vaccines.
Given all that we've talked about regarding health inequities, COVID-19 related and not, I'm also sort of curious to hear your thoughts about how those inequities might be impacted if many people in our community decide to wait to take the vaccine. If we want to see how it fares, after a vaccine is approved, if we want to see how it fares in other groups before we decide to sort of accept it as an option for us, what does that mean for the inequities that we've talked about?
Yeah, I think that's a fair point. What we're going to see if there are not a large number of African Americans who are vaccinated about COVID-19 is we're going to see these disparities increase. We're going to see higher rates of hospitalizations, higher rates of diagnoses, higher rates of deaths, potentially in Black communities. That's if we have an efficacious vaccine. And that's something that I think we all need to be concerned about, that there's a cost here. There's an opportunity cost if we are not taking the vaccines. But there's also an opportunity cost for other diseases and other issues. We're right now going into our third wave of COVID-19 in the US. What's probably going to happen is we're maybe going to see lockdowns again in many of our various areas. What does that mean for access to healthcare for African Americans who need it? We've already been seeing that Black women are less likely to being tested for their mammographies for breast cancer during the COVID-19 pandemic. Well, we're already seeing higher rates of substance use and deaths and hospitalizations among Black substance users during the COVID-19 pandemic. We're already seeing high rates of child immunizations that are not taking place during the COVID-19 pandemic. And we're already seeing high rates of ICU beds that are no longer available in particular states as cities during the COVID-19 pandemic as we move forward. What does that mean for other things that affect us disproportionately if we're no longer able to access that because not a sufficient number of us who've taken the vaccine while rates are increasing as we go through this third wave? So, there's opportunity costs in terms of COVID-19 and how that affects us, but also opportunity costs in terms of other diseases that affect us that it's much difficult for us to get access to, healthcare access to, as we go through this third wave of COVID-19.
Anyone else?
I certainly agree with Greg. It's if you don't take the vaccine, it's very likely that the one would get infected, and so the risk of death. So the threat is real. I think having ways to increase, I would say it's much more of increase the comfort level. And I think that it's real that the same way that people are worried about taking the flu shot, I mean, it's gone over the years, but the same concern is the same concern about the COVID vaccine. And so just having a way to make sure that a number of the community-based organizations are reaching out to our population to make sure there's a good understanding of the risks and the benefits would certainly increase the uptake, right, of people being willing to take the vaccine. So I think that organizations in the Black community, in the Latino community, should make efforts to increase the awareness and the understanding so that people are more able to be trusting and able to take the vaccine. But I also think that a major way of addressing this is how the message comes across. I know Greg had talked about both the message and the messenger, and I think that that's very important to get that message across because of the risk, right? There's a real threat. Already we're at risk. Already we suffer disproportionately, both from the morbidity and the mortality of the illness. So we don't want that disparity to continue. We would want for everyone to be protected as much as possible, but also that the producers and the government and have put efforts in place to make sure that the processes that are taken to produce this vaccine are transparent in such a way that people feel more comfortable, I think is a very critical part of what needs to be done.
The other thing that I guess I would say is that you need to provide people with examples. You need to have testimonials from people who have taken the vaccine that they trust or that they know, so that they feel secure in this. That's the other part. You know, again, let me see who has taken this, and let me see that they're still alive, or that they haven't contracted this particular disease, or somebody who had it, they took this particular medication and they're fine. That's the thing that then, again, the source. It has to be somebody that is credible, that they can trust, to present that to them.
I'm glad that you mentioned that. I think that is a really nice segue. So we've talked about this notion of trust, and I think about the message and the messenger. I guess I'm also sort of thinking about the role that media plays in all of this. To your point, Vivian, I recall reading a couple of articles about HBCU presidents who decided to publicly announce that they are participating in a clinical trial for COVID-19. And the feedback and response, to that, I think it was very interesting. So, I guess I'm sort of curious, what does it mean to really be the messenger? If you are a person in a position, a key role in a Black community, in a Black organization, and you say, this is what I'm doing, this is what this means, and the feedback to that from our communities. So I guess I'm just sort of curious to hear your thoughts about that, about, what does it mean to be the messenger, the role the media plays in this? And then I have another question regarding the clinical trial process that I want to ask.
Well, I'll just say this, having read about the presidents, and I understand their position, and in stepping forward and recognizing the need for participation of their community, and recognizing that they were willing to make that sacrifice for their community. And I have the utmost respect for them for doing so. Now, listening to some of the parents when they encouraged the students to do so, that was a little, that caused me a little alarm. I would, again, my big thing is transparency, making sure that it is informed, clearly informed. And again, making sure that they're not being swayed simply because, oh, this is my president, so I got to, jump in. As somebody who, at some point in time, as we continue on with this, yes, I'm probably going to be charged with recruiting and making sure. And the thing that I want to make sure of is that whatever I'm advocating or supporting, that I have been clearly transparent with that community. I do understand that I'm telling them, like I train community health advisors on health advisory boards. And I tell them, don't look at me because I'm gonna be the person coming to you. I want you to question me. You don't come in and just rubber stamp a proposal that I put in front of you. You come in and you've been trained, you know the questions to ask. You know what your rights are. Go ahead and ask. Assume that everybody is suspect until you get your answers. And I think that it's important. It's important for us to participate. I think as someone who has to go out and recruit these individuals, there's a great burden on us to make sure that we know clearly what this study is about. We know its level of not only effectiveness, because it's something can be effective, but it's not safe. Okay. So we wanted to make sure that it's safe and that it is effective and that it is accessible. A lot of drugs that we see out here now, are people can't afford them. They're not available to them. So, and half the time I'm going around trying to find different groups that will pay for medications for a lot of people. So you have to be, again, transparent and honest, and you have to allow people to say no and understand that and recognize that there's nothing wrong with them refusing, and there's nothing, I'm not going to glorify you and just pray, because you decided to. I want it to be your decision because it's what's best for you. And it's what you wanted to do. Like I say, when I talked to those presidents, I found out that they felt it was their duty to their community. And that was wonderful for me. Like I say, I have the utmost respect for them for doing so. But at
one
the
thing.
same time, go ahead. I'm sorry. At
No,
the same
no.
time, I just like for them, the young people, to be able to say no, and that be okay too. Okay.
Yeah, and one thing that I would say too is that just because someone is saying no doesn't preclude them from saying yes afterwards. And in some ways, I think it's perhaps going to be more powerful that as time goes on, as we build more trust in the COVID-19 vaccine, if those same presidents came forward and say, yes, I will take such and such vaccines now, that has an impact because these were people who were formerly skeptics who are now voicing more confidence in it. And I think that we're probably going to see some changes in opinion as well too, just in the next couple of weeks. I mean, we have to realize that a lot of the mistrust as well, a lot of the skepticism that's tied to the COVID vaccine process is because of the politicization that's taken place. We're having a national election that's taking place November 3rd. If there is a different administration that comes in after November 3rd, it's going to handle the COVID-19 vaccine process very differently. And if that happens, we're probably going to see differences in opinion as well from the American public and specifically from African Americans in terms of trust of COVID-19 vaccine. So again, I just want to say that just because someone is saying no now doesn't mean that they're going to be saying no in the future.
That is a really, really good point. And that everyone falls somewhere on the trans theoretical model stages of change. And some people will move, from one stage to the next based on different information. And I think, I guess I'll go back to the comment about the messenger and the message and how that might be catalyst for someone to move from one stage to the next in the process of considering participating in a clinical trial. One question that I definitely want to ask regarding I think, the media, but it's come up quite a bit in conversations and communities about trials that have paused. And I would love to hear from one of you or all of you, what does it mean that a trial has paused? And what should communities be thinking about or considering or asking themselves or of researchers when they hear about study pauses?
Well, let me say this. The first thing that comes to mind when a study pauses, like AstraZeneca, they said, someone developed, had an allergic reaction. And then I think a couple of days later, a couple of days ago, I heard someone that someone died. So I'm going, okay, what happened? When was it, you need to be transparent about those instances. How were they handled? What actually happened? Let them know. And then how did you, as a pharmaceutical company, how did you handle this? How did the researchers, how did you handle this? And why did you move forward? Or what corrections did you put in place? I would want to know those things, because until I know that, I'd be like, no, because that if you tell me there's a 1 in 10 chance, I know I'm gonna be that one. In my mind, I'm gonna be that one. So as long as I know, okay, this happened, it was not related, and this is how we know what it was related to, or even if it was, this is how we countered, and this is how this has changed, and these are the results. Just explain it. Just, again, the transparency component. People are more understanding than you think.
I know one of the comments that I've made in other spaces is that trial pauses are also representative that the mechanisms that are in place to protect the well-being of study participants are working. So I think that's something I also want to bring up in the conversation. The other question that sort of pops into my mind is, for folks who may be considering joining a trial, if you could think of the sort of top 3 to 5 things that this person should consider in bullet point sort of form, what would those things be?
I would think about having a good idea of the risks and the benefits. I think it's really important to have a good idea of the risks and the benefits before you participate in the trial. The benefits would be that it's important that we have that trial. It's important that populations are adequately represented to make sure that the vaccines are efficacious in all populations. But on the other hand, there are risks of participating in the trials. The organizations or the pharmaceutical companies that are developing these vaccines have protocols to try to pick up on potential infections with COVID. There is that risk, of becoming infected, but there are also protocols that are being rigorously evaluated to try to make sure that there's safety in participating in the trial. So that's what I would say.
Yeah, I would also say that, there's probably going to be multiple opportunities to participate in trials. So there's not just one vaccine trial that's out there, depending upon your area. There may be an opportunity to participate in a particular vaccine trial where perhaps the characteristics of that vaccine, how it's administered, or anything else about it might make you more comfortable to participate. So I think people should definitely, do their homework. There's different vaccine trials that are out there. And if there's one trial that you don't think is for you, it doesn't mean that there isn't a trial out there where you may feel more comfortable participating.
That's a good question. I think just be honest with yourself. What is it that I need or want out of participating? What's important to me? Is it important to me that I make sure that my community is represented in these trials? Is that important to me, or is it important to me that I protect my community? So I'm going to participate in this so that my community benefits. You just have to be honest with yourself about what your motives are for engaging. What's important to you?
Thank you for that. And finally, before we get to your final comments, the question of the day. If a safe and effective COVID-19 vaccine were to be approved at some point, would you take it? Would you recommend it to your family?
Unequivocally, yes, for me. That yes, I would take it. Yes, I would recommend it for my family. I feel fortunate. Most of the people in my family are in the healthcare profession. They're nurses, they're doctors, microbiologists. I'm a scientist myself. And we would definitely discuss, and I know that many of my family members would take it because most of my family members are healthcare professionals. They have to take vaccines anyway. They take the flu vaccine. They've taken other vaccines that are available to make sure that they don't get anything that they can pass on to their patients or people that they're treating. And I know that likewise, if a safe and effective COVID-19 vaccine is available, that they would take that as well. I would also take one as well too.
So the same for me. I would take it, and I'll recommend to my family members to take it. I would want to know, I would want some transparency in knowing how rigorous they were in ensuring safety before I would feel comfortable taking it. And once I know that, and I'm sure of that, then I would feel comfortable recommending that to my family members.
I have to echo that in order for me to take it, I would have to know the rigor of of review of this. I would have to know again the level of safety and efficiency before I would then take it, and I would take it first before I recommend it to my family. I'm like this: if it's something wrong, then and I recommended it to my family without me taking it first, I would feel terrible. Let me be that one, and then I'll let you see me, and then we'll take it from there. But there'd have to be that transparency. There would have to be. I would have to know the rigor that was involved in that, and I would have to know the level of efficiency and safety involved with this particular vaccine.
Thank you for that. This has been a very interesting conversation. I am very happy to have you all here and to be able to talk with you about all of this. And I think more so, I think it's important that other people get to hear from you. And not just in terms of your perspectives, but also your transparency and what does this all mean and look like for you as well. I want to take a moment now to allow you to say your sort of final comments or final thoughts. If you could take 30 seconds to a minute to sort of give your final comments or thoughts, that would be great, and then we will conclude.
I would say that it's important, again, from a clinical perspective, that we have adequate representation in the trials. And so I think it's very important that I encourage everyone to think about it, knowing the risks and the benefits in participating in trials. I would also say that prevention is key to any disease at all in medicine. So as much as possible, I would encourage everyone to be well empowered with knowledge to be able to make a difference in your life and in the life of your family members. And so it's very important that you're well empowered in knowledge. Medicine is out there essentially on the internet. So you're able to read and you're able to know and you're able to empower yourself and equip yourself with knowledge. So I think that that would be what I would advise everyone to know, to be well empowered in knowledge and to take measures to try to prevent disease, whether it's COVID, whatever disease, as much as possible to try to prevent is key.
Yeah, I think the only thing that I would say is that, when Stefan asked me to be a part of this podcast about a month ago, I basically told him that I voiced my own skepticism around the vaccines themselves and not sure if I would take a vaccine. And I've changed my mind since then. And I think that we need to give a lot of people in our community the latitude to really consider the data, to look at what's happening, the evolution of the vaccine trials, because those who were just as skeptical as I was might also change their mind in time. And there's many other events that are going to be taking place soon that could influence their decision. So I think that if we are operating from a point of shaming people, if we're operating from a point of telling people what they should or shouldn't be doing, that's not going to move opinion. We need to give people enough freedom, enough information, enough transparency to make these decisions on their own, just like I did. And I think that that's what's going to get us ultimately to a place where we all want to be, which is reducing COVID-19 in the Black community.
I would just say this. This is the reality. We have to deal with the reality. And the reality is that it is our community that is impacted by this most. And, we can't sit on the sidelines. We cannot sit on the sidelines. And we've got to get involved. But again, I'm going to echo this. It requires commitment, not just of the individual, but it requires commitment on the whole system, the whole process. And so we've really got to attack it, not from the bottom up, but from the top down. And so that means investing in the researchers, the educators, the physicians, as well as making sure that when you start communicating about this, that you are transparent. And that, yes, you respect the autonomy of the community. Because, these diseases they don't discriminate. They will get you. So we all have a stake in this.
Thank you for that. This concludes our session, episode 3 for today. On behalf of the COVID-19 Prevention Network, I want to thank our panelists for taking the time to speak with us today, sharing their voices, experiences, and themselves to bring attention to some very important issues in a time when we're all looking for answers and a way forward through this uncertainty. I also want to thank you all who have attended this episode of COVID in Black, and we hope that you found this episode enlightening and informative. Please stay tuned for future episodes. If we did not get to your questions in this session, please follow and engage us on Facebook and Instagram at Prevent COVID-19, and visit our FAQs on our website at www.preventcovid.org. The recording of this episode will be available on the CoVPN Facebook page, as well as our YouTube page. If you're interested in learning more about the COVID-19 Prevention Network, have general questions about clinical research, or considering volunteering for a COVID-19 trial, again, please go to www.preventcovid.org. Thank you again. Have a great day and a great week.